Alright.
Hello, good afternoon. Just hold on. Good afternoon. I would like to thank each and every one of you for being here with us at this live session from MAHSA University Sarjana Putra campus. Hi, my name is Mastura. I'm a nursing tutor from School of Nursing, Faculty of Health Sciences, Nursing and Education, MAHSA University, and I will be moderating today's session. So today's webinar, in Stage of Renal Disease, a Nursing Perspective, is proudly organized by the Faculty of Health Sciences, Nursing and Education, MAHSA University. Dear viewers, before we proceed further, I would like to give you a brief overview of the programs offered by the Faculty of Health Sciences and MAHSA University. Our Faculty Health Science and Nursing and Education consists of School of Education, School of Physiotherapy, Department of Environmental Health, Department of Medical Imaging, and School of Nursing. And School of Physiotherapy from Diploma in Physiotherapy, Bachelor, and we have also Bachelor of Physiotherapy, ODL, as well as Master of Physiotherapy. And for Department of Environmental Health, we have Diploma of Environmental Health, and we have Health and Safety Hons, Bachelor, yeah? And we have Bachelor of Environmental Health and Safety, HONS, ODL, and as well as Diploma in Occupational Safety and Health. And as for the Department of Medical Imaging, we have Diploma in Medical Imaging Radiography, Bachelor of Medical Imaging HONS, and we have Bachelor of Medical Imaging HONS, ODL. Why join health sciences? It is a very high job demand, and this is essential services, yeah, and low risk of job redundancy. You cannot be automated, and no boring work routine, lucrative remuneration, opportunity to work in variety of settings, a career you can feel good about. As for Master of Physiotherapy, it's a 1 year program full time and a 2 year program part time. These are the entry requirements. Okay, as for bachelor degree, it's a bachelor degree level 6 MQF or equivalent with minimum CGPA of 2.50 in related field as accepted by the AGP Senate, or a bachelor's degree level 6 MQF or equivalent not meeting CGPA of 2.50 can be accepted subject to a minimum of 5 years working experience in the related field. As for English proficiency for international students, IELTS Band 5, TOEFL PBT is 410 to 413 points, or TOEFL IBT 34 points. Yeah, these are the program offered. Yeah, and the entry requirement. As per matriculation, pre-university STPM, minimum of GPA 2.33 in two of the following subjects: biology, physics and mathematics, chemistry, A-level, minimum grade D in two of the following subjects: biology, physics, mathematics, and chemistry. And as for diploma, minimum CGPA of 2.75 in related field, or CGPA less than 2.75 in related field, and minimum of 3 years working experience. Yeah. And these are the diploma in physiotherapy, diploma in environmental health and medical imaging entry requirement, SPM pass in Bahasa Melayu, in English, and 5 credits in the following subject: mathematics, one science subject, and other 3 subjects. As for GCE in O level, pass in Bahasa Melayu or English, and 5 credits C in following subject: mathematics, one science subject, and any other 3 subjects. As for certificate level 3 NQF in the field of health science with minimum CGPA of 2.75. And as for the diploma in occupational safety and health, entry requirements are SPM, pass in Bahasa Malaysia in English, and 3 credits in the following subject, yeah, mathematics or one science subject, any other 2 subject. As for O level, pass in Bahasa Malaysia in English and 3 credits grade in the following subject, mathematics, one science subject and any other 2 subject. As for certificate related health sciences with minimum CGPA of 2.50. MAHSA University and infinite excellence is what MAHSA aspires to provide for each of its graduates. And why choose FOH MAHSA? Of course, we have experienced and dedicated international pool of academic staff, and we have interactive teaching and emphasize on hands-on clinical skill, face-to-face and online platforms such as LMS. And we have wide list of hospitals, institutions for clinical and industrial placement. And we are also accredited by NQA and GBA with international recognition. We have dual award with ARU. And we have also various study modes, conventional, open and distance learning, cross-teaching by expert, and MASA has the most number of health disciplines in single institution among IPTS. MASA scholarship is Haji Abdullah Academic Excellence Scholarship, Foundation of Scholarship, Blue Ribbon Scholarship, School Teacher Scholarship, Family Scholarship, and the Single Parent Scholarship. And these are the collaboration and affiliation from with MASA. And we have Student Mobility Program. This is from Aryo Sosei University. Sorry, my pronunciation. Okay. And we have all these lovely professional university with us. Yeah. The activities. Huh? And we would like to welcome you to join us at MAHSA University. We are committed to your learning. Thank you. So today we are going to introduce to you in stage of renal disease a nursing perspective, and we have our speaker, Mr. Muzahir. But before that, I would like to a glimpse of what is going to be presented by Mr. Muzahir. Um, the Gallant Center says Malaysia is one on the brink of a kidney disease crisis. In fact, SOCSO spent almost RM 1.22 million on dialysis for its contributors in 1999. This increased whopping 27 times in 23 years to RM 334.67 million in 2022. So over 51,000 Malaysians currently live with end-stage of renal disease. So Malaysia government plays a pivotal role in supporting the 17 Sustainable Development Goal, SDGs, by addressing end-stage renal disease through comprehensive healthcare initiative. Malaysia approach encompasses several SDGs, primarily focusing on good health and well-being. That is SDG 3, clean water and sanitation. SDG 6, and Malaysia ensures access to quality healthcare services for end-stage renal disease patients through subsidized treatment under various public health schemes, promoting SDG 3, effort extend to preventive measures and health education aligning with SDG 3's target of reducing premature mortality and promoting health education. Furthermore, partnership with healthcare provider, NGOs, and international organizations illustrate Malaysia's commitment to SDG 17, fostering collaboration to strengthen healthcare infrastructure and capacity building. Without further ado, Now let me introduce speaker of today's webinar, Mr. Muzahir Muhammad. He is a registered nurse specialty in program coordinator post basic renal nursing, MAHSA University. Clinical experience Clinical experience as nurse of 7 years at HUKM and National Guard Hospital Saudi Arabia, and academic 4 years currently in MAHSA University. And Mr. Muzahir currently in his final year master in nursing. So let's welcome Mr. Muzahir. The screen is all yours.
Hi. I hope everyone can see and listen on me. Thank you so much, Madam Mastura. She was my very senior lecturer in our School of Nursing, and it's very honored for me to be introduced by her. So yes, I'm Mr. Muzai, and I'm currently a program coordinator and also lecturer for School of Nursing MAHSA University in Bandar Sarjana Putra, Malaysia. So my major core is in renal. It was in renal nursing specialties, and today I would like to present. It's not presentation, some sharings on what is actually happens in our country, Malaysia, regarding the kidney disease. So let me introduce back. My topic was on kidney disease crisis in Malaysia on the nursing perspective, supporting the 17 Sustainable Development Goals with government strategies. Some contents. So I have laid out few contents. First on the introduction on ESRD and what is the 17 SDG goal. Okay, what is government of nation strategy have been done to managing this issue, and some recommendations and conclusions on the nursing perspective. So we start on the kidney disease crisis in Malaysia. So basically, on this year's, okay, there was a many issues that happens related with the ESRD. Okay, some news was mentioned that Malaysia is on the brink of the kidney disease crisis, and also nearly about 10,000 new kidney patients are required dialysis every year. So from these issues, from this news, I think like this is kind of like worrying, should be worrying from, it's not only governments, but as for us nurses and also healthcare provider, it should be something that need to be concerned to ensure Malaysia will sustain financially and also health in futures. And also Malaysia kini diambang krisis penyakit buah pinggang, and some also corrected from the code blue, Malaysia's second fastest rising kidney failures globally. Okay, let's go some introductions of kidney disease. One of 7 out of 34.6 million populations that are having various stage of kidney disease, CKD. So CKD is like, when I stop CKD, it was chronic kidney disease. So diabetic mellitus continues increase in Malaysia, and it's now leading the causes of the ESRD, accounting of 65% from the all cases. And almost 50,000 dialysis patients in Malaysia are now currently ongoing the treatments, and in both hemodialysis treatment and also peritoneal dialysis. We go some briefing because I think like this webinar is open for publics and also healthcare provider. I know there was nurses, students, so kidney disease, it's okay, but some introduction for those that news in these terms. So kidney disease consists of 3 conditions. Okay, first is acute kidney injury, which is the sudden decrease of kidney functions, which is where the kidney is unable to filter the waste products in few hours to the few days. And next we go to CKD. CKD is a gradual loss kidney function over the time, which it can be start from AKI lead to CKD or AL itself. Patients can diagnose when at the CKD phase. And the last one is ESRD, end-stage renal disease. So end-stage renal disease is actually the last stages. Out of 5 stages, ESRD is the last stages of this gradual loss of this kidney disease. So from KDIGO, and also this KDIGO is the guidelines, classifications that nation had been established, and also Malaysian government from Nephrology Service Department, Public Health Ministry of Malaysia from 2018 suggest for our Malaysian country are using these stages and classifications to rule out and also to diagnose our CKD patient in Malaysia. And basically, how to diagnose CKD it cannot be simply like when you see like the swallowing at the leg, or patients are increasing urea in the blood results in patient FBC and also creatinine. We cannot simply diagnose patient with CKD. However, the using of estimate glomerular filtration rate (EGFR), and also which is this is include the serum creatinines and also patient cystatin. From the results, we can identify the stages of CKD. And also not to forget that KDIGO suggests to identify what is the causes, either what is from pre-renals, or it can be from diabetic mellitus, hypertension, or it can be from the post-renals, prostate hypertrophy, or kidney stones. So, and also it's need to be combined with the albumin urea level, and of course also the creatinine level. So from this kind of we call as a parameter, we have to combine together to diagnose patients in what kind of stages that patient have. Why does it very important for us and also for healthcare provider to able to identify? It's not if you're still new in nursing, of course you will might be like, why should I know the stages? Why should I able to diagnose these conditions? Of course, why these stages classified is differently is because patient clinical manifestation and symptom. And from G1 stage 1 to stage 5, there was a various of clinical manifestation that our patient will come to us. And of course, as a nurses, it's very important to identify which stages and how we can manage the condition of the patient. So this is marker for kidney damage. So we can using the albumin urea patients for the 24 hours albumin urea. Okay, urine sediment abnormalities, it can be through by observation and also from the microscopics. Electrolytes and other abnormality due to tubular disorder, like the accumulation of sodium and potassium in blood, which is where the tubular of the nephros unable to play the main roles. And also there was abnormality detected by histostructures, can be detected by imaging. It can be by KUV ultrasound or X-rays. And also if there is any history of kidney transplantations, because as just nice to know that if patients are having kidney transplantation, there was one issue that we need to be really concerned, which is rejections of the graft. So when the rejections of the graft, of course, patient will lead to the kidney damage. So that's why kidney transplantation, history of kidney transplantation is become markers for this kidney damage. From the nephrology service, Department Publics, this is kind of 2008, but I will show you why, even though it's from 2018, but it still can be used until now. Just stay tuned. So government was mentioned the non-communicable disease risk factor Malaysia for that age is the numbers Malaysia with CKD significant increase, okay, due to the diabetes and hypertension. However, there have been list out few factors that need to be considered. If examples, these patients, the community of our patients have one of these point, they have to be monitored for CKD. So those with the age of 65 years old, patient with obesity, because obesity we know there was a issue with the cardiovascular system, cardiovascular disease like hypertension. Of course, hypertension can damage the patient's glomerulus, metabolic syndromes, usage of the drugs, family history of CKDs and kidney disease. Patient with gout, of course, arthritis, it can lead to increasing of acid, which they can lead to the damage of the glomerulus patient. Multi-system disease with potential kidney involvement, structural renal tract disease, and also any hematuria dan proteinuria in patient. NRR, National Renal Registry, has laid out few primary disease, okay, from 2020 until 2012. But in 2012, we can see the highest causes the primary renal disease, mean like the etiology for this CKD, of course, if you can see from the diabetic mellitus, it was bring 52% out of all. And also second one is on hypertension, it was 34.8 from 0.8 from all. Because if you see, like, that's why government Malaysia is very concerned on how to manage the diabetic mellitus and also hypertension, because these etiologies can lead to renal damage. Okay, and also how some introduction also how when patients are having this end stage renal disease, and the main treatments that we have to include in our management is kidney replacement therapy, or we call as a KRT, or before we call as a RRT, renal replacement therapy. So the choice between dialysis and transplantations is depend on the various factors, especially patient age, what patient wants, what is the financial status that patient have, and what is the sign symptom. If there is any access for the access, and of course there was any kidney donors that available. And lifestyle patient, we have to convert patient to hemodialysis. If patient cannot do hemodialysis, we have to convert patient to CAPD. And other medical history, that some kidney transplantation, because kidney are very limited, so that's why we have to screen patient on the medical history. Not all patients are are suitable to get the kidney from the donor. And this three I list out here is one, first is CAPD, continuous peritoneal therapy. Second one is hemodialysis, and third one is kidney transplant. So what is the advantage for these three replacement therapy? Like when patients are diagnosed with ESRD or CKD stage 3A, patient have to choose one of these modalities. So each of these modalities, of course, they bring their own benefit and also disadvantage itself. So for CAPD, this is home-based treatment, because patient, when we can provide a patient on the home-based treatment, patient don't have to travel to a hemodialysis center. So it's very appropriate for them. And also this continuous, this CAPD is a continuous treatment, where the CAPD helps, the principles are helps, like how the normal kidney function work. And of course, a patient with having the fewer dietary restrictions, of course, who is in Malaysia don't want to eat, who is, when you are humans who don't want to eat, right? So if you want to eat, if the patient, like they say, like, I want to improve my quality of life, I want to eat and drink like better. And of course, CAPD is the best for them, because CAPD, they provide the good the good removal of waste and also the fluid. And CAPD also provide the preservations of residual renal function to patient, because in CAPD we're able to manage patient hypertensions appropriately. So that's why these reservations of residual kidney functions can be done in peritoneal dialysis. The second one is hemodialysis, for also if not all patients are suitable for CAPD, so we can go for the hemodialysis. So why hemodialysis is very advantage? Because it was effective waste removal, because we can adjust on the patient QB and QD side. So by doing this, we're able to adjust how much we're going to reduce the urea and also creatinine patient. There was a regular schedule which patients are able to manage the life and daily schedule, clinical support from nurses and also a physician, because if they're doing the peritoneal dialysis at homes, they cannot be monitored. If there is any complications happens, it cannot be monitored by nurses. But however, in hemodialysis, there was be done in the center. Of course, you've been monitored by nurses. And also the kidney transplant is the best renal replacement therapy, which this kidney transplant, the real works like how the normal kidney, which this can improve the quality of life. And there was also long-term survival, which no dialysis sessions and reductions of medication, because in HD and PD patient, hemoglobin will be reduced, so patient will be on the stimulating agents and some anemic medications, but not in the kidney transplant. However, in kidney transplant, there was a few medication we call as the immunosuppressive drug that patient have been take for the whole life. Okay, so and I also report the incidence of the new kidney replacement therapies. If you can see from the numbers, it was gradual increasing year by year, which is on the 2002. there was almost 10,000 patients ongoing the hemodialysis in Malaysia. And for hemodialysis patient, about 7,000, and new peritoneal dialysis is about 2,000 patients. And from the graph, we can see like the increasing renal replacement therapy, including the hemodialysis and also new transplant. So if we see the increasing of new kidney replacement therapy, of course, the number of ESRD also increasing. However, if I'm saying that I'm saying just now that if the kidney replacement therapy is the best choice for patients because of due of lack of donor in Malaysia, the kidney replacement therapy for the transplantation is reducing year by year. So I think maybe we need some awareness for patients to donate the kidneys, because people actually can live with one kidney, should be no problem. So this awareness is very important. And why we want to convert patient, why we're going to advise patient, we want to improve the kidney transplant in Malaysia. Of course, we can see if patients are ongoing for the dialysis, the numbers of that, okay, due to cardiovascular systems, die at home, infection, GIT bleeding, cancer is increasing on this 2020, which is the percentage is 25% for cardiovascular disease, and others, the second highest was the infection, because of course we know patients on dialysis, there was central vascular access or patients on fistula. So these two access will lead to increasing the risk for infections to the patient. And same goes with the hemodialysis patient. You still cardiovascular is the highest. Like for the peritoneal dialysis and also hemodialysis, both is lead by cardiovascular. Means like when patient are having hypertension or hypotension itself, will lead to the death for the patient. Okay, so let's see how the nations, okay, United Nations, we go a bit further, United Nations, because as we know, like Madam Mastra has mentioned early on the Sustainable Development Goals. So this Sustainable Development Goals is by United Nations, where our nation are together suggest and we are agree to having this SDG goal during years of 2030. Okay, so there was 17 SDG goal, basically on the no poverty, number 2 no hunger, number 3 on the good health and well-beings, and you can see here, but now I'm going to focus on the number 3, which is good health and well-being, where in this in this number 3 SDG goal, there was mentioned on the good health and well-being. So good health and well-being is identified like people can have their life like a normal people, they can eat like a normal people, they can walk, they can talk, they can work like a normal people, like how we are growth with this called as a well-being, human well-being, like what's supposed to be human can done, it should be done. And also it's not only by the physicals, it's only consists of mentals. So the goal number 3 is ensure the healthy life and promote the well-being for all at all age. I mean, like if starting from your born until old or even you die, peoples or we should achieve this goal number 3. So there was a few actually point in this goal number 3. I just take up 4 that related with this is ESRD. First is on the health financing, which is this goal they urge Malaysia to promote more. Okay, I mean like they want Malaysia or governments to provide more financial support on the healthcare systems, and also they urge for universal health coverage, including for the insurance and medical assistance and also the facilities. Third, on the tobacco control, because we know like this tobacco can lead to hypertension to the patients, so that's why they urge to control this tobacco and strengthen the capacity of strengthen the capacity of all countries. I mean like from the developing countries and how the governments give the early warning sign to the patient, reduce the risk, and how on the primary and secondary preventions need to be done to our community. And on what is the strategy of the Malaysia government in managing this issue? That's mean like what is, because United Nations has urged Malaysia on and also other country to able to achieve this SDG goal. So what Malaysia have done is actually, because it is very important as a nurses, I think for me it's very important to us to know and identify what is Malaysia have done, what is the guidelines, what is the, how we going to manage the ESRD. So nurses have to know this, because of course we one of the team that going to make sure these goals are achieved. So on 2018, government has established this one strategy and program we call as a Nation Action Plan for Health Kidney. So we call as 8KID lah. KID is kidney disease. So this plan was established on 2018, and of course the goal was expected to achieve in 2015. So now it's 2014. How we think that within 1 year we can achieve the goal. So it's back to us. It's back to us nurses and also healthcare providers. How we going to make sure this plan are achieved? So the main objective for this action plan is actually on the primary preventions and also the early detections and secondary prevention. So primary preventions, of course, on the awareness, how we're going to manage patient diabetic mellitus, how we're going to manage patient hypertension, what is the medication that should patient have, what is the for the numbers, like the range for the blood pressure that patients should achieve. And on the early detections and secondary preventions, if patients, we have like 5 stages of CKD. So how we going to able to make sure patients are, the detections at the early stage, which is when we know in the early stage, the management will be lesser. And for the treatment to be better is high chances. And also this goal also to expand, enhance, and also to enhance the treatment options for patient with ESKD, and also to develop and maintain the strong research component to guide kidney health policies and practice. So the focus of the plan, of course, one is to reduction the burdens of disease using the multi-agency approach. Okay, what is a multi-agency approach? Is like per case, so our SOCSO and also governments, NGO, and also WHO, including on the screening, prevention, and early treatment of CKD. For example, like if patients are stage 3 or stage 1 AKI, right? So we have to manage this. We have to manage this condition at that stages to prevent it to be more worsened and lead to ESRD. And focus number 2 is timely and appropriate preparation for renal replacement therapy, including the renal transplant, dialysis, and also palliative care. So, like I mentioned before, there was a 3 RRT, renal replacement therapy. But if, let's say, if patients have a lower chance to survive in these treatments, we have to go to palliative care to the patient. And number 3 is to increasing the rate of renal transplantations and also to shift to home-based dialysis treatment, increasing the access to peritoneal dialysis. As this code blue mentions, half of dialysis Malaysian won't lifelong enough to receive a kidney transplantation, which is like if patients are ongoing dialysis, they're waiting for the kidney, but they cannot want lifelong enough because the kidneys are very limited, okay, compared to the numbers of patients that request for that. And as you see, like the new kidney transplantations on 2012, only 212 compared to other dialysis. And what is the target of the Malaysia? So like if I say like what is the target? So on 2025, what is actually the target that we have to achieve to make sure these strategies and program are achieved? So they list out 7 of the indicator of the target. Okay, first on the risk premature mortality from the cardiovascular disease and the prevalence of the tobacco in youth person age of 15 years. Mean population intake sodiums, because we know sodiums like it can lead to hypertension. The prevalence of insufficient physical activities, use of the alcohol. The global target is 10%. Prevalence of risk of the blood pressures 25%, and also prevalence the diabetes and obesity at the heart rise. I mean, like is low possibles, so it's better for us. So as I know, like what Malaysia have done. So what is our nation have done is actually, so the combination like collaborations from the many NGOs and also organizations is actually helps our ESRD patient to survive in their dialysis and also the kidney transplant. Because of course the treatment is not cheap, and for me it's so expensive because there is no money resource from patients unable to continue the treatments. That's why we have to thanks to governments on these collaborations strategies. So the government funded was only 46% from out of these treatments, and also the contribution from SOXO, Zakat, and also NGO like NKF, self-funded. Okay. And why is actually if patient, like I said, not all patients are suitable for PD, right? So because why PD they have like some connectology, because we call as a connectology, where the patient have to connect all the device itself. There was no any clinical assistant from nurses, so not everyone can able to perform this dialysis. However, we can see like patients can having this complete assistant, which is patient can do the PD peritoneal dialysis with assistant from their relative, or may they have like their assistants. So we can see the numbers of completely assisted PD is about 1,500, which is it's okay if you cannot do PD, you can have assistance. So to not able to do PD for patient for themselves is not one of the, I mean, one of the thing like we can, you cannot go for the PD, we can do for assisted PD. And some recommendations and conclusion. This is also is like I mean, like these discussions, I go for the evidence-based practice, some evidence from the clinical guidelines, and also what is the Malaysian and nations has been established for this. So the collaborative approach, that's mean like to manage this CKD, we need the strong clinical overlap between diabetics, cardiovascular disease, and others to develop the programs and activities to controlling this issue. So this collaborative approach should be based on the patient-centered care, which is like patient on the centers, like other healthcare provider, nurses, physician, pharmacists, dietitians should be collaborate together to improve the patient care. Multidisciplinary and collaborative team from cardiovascular team, from diabetic clinics, from like renal discipline. So we collaborate together to improve patient outcome. Accessibility of the service, like now we know like there is a lot of hemodialysis center out there, which is this hemodialysis center are providing the accessibility service to patient to do their hemodialysis better. But however, we may need a peritoneal dialysis center to be established more. So when one time patients are converted to peritoneal dialysis, they have a good accessibility to the service. Safe and high quality based on the evidence-based practice, and also of course the population health approach, because we go as a one nation, as a Malaysia, population healthcare approach is very important. So because we look our health in as a one community, is not as a one individuals. On the primary preventions, okay, primary prevention should be focused on the nutritional, smoking cessations, and also physical activities. So what we can do in this primary preventions, of course, the screening of the high risk group for those patients, like those working in the stress areas. So we have to screening for the hypertension, for the blood result. I mean, like for the blood pressures, and yeah, for the kids, for like if you know, like on the primary healthcare in the clinic, like they do like awareness. And also nowadays there is a many NGO, they will go to the community to provide the service of these screenings to identify the early complication of hypertension and also the diabetic mellitus. And because of the diabetic mellitus is become the first causes of ESRD, glycemic control is very important. This is basis on the diet patient and also the use of anti-glycemic agent, smoking cessation. That's why there was many establishments. If we go to government, we listen on the smoking clinic. Okay, so this smoking clinic purposely to help patients to stop from the smoking. Medication management relation to kidney disease, like we know, like NSAID, the use of NSAID and also ibuprofen, nasofen also can lead to AKI. That's why the management of this medication is very important. Like if we know that these patients have a risk to CKD, the uses of NSAID are prohibited for them, so we can like maybe reduce the uses of NSAID. And to provide an integrated service in CKD detections and managements, like this objective is like we're going to increasing the community awareness on kidney healthcare, CKD risk factor through the partnership NGO and also civil society organization. Like now we have like CKD, there was a many NGO actually in Malaysia. They're providing the service, they're providing a free service on these early detections and awareness to the public. So Malaysians and also nurses should work together with this NGO to give awareness and a screening for the early risk. Empowerment patient self-management, CKD and hypertension, we have to include patient together in managing the issue, provide information, training, ongoing support, and the healthcare professional on CKD. Like example, we send our nurses for post-basic, we send them for the degree, so they have like better knowledge how to managing their patients well. And also the establish of sustainable multidisciplinary collaborations and community health approach to meet the needs on the CKD. It means like we should establish like now we have like we call as a community works like hospice, right? So we have like hospice for them to do home visit, but it's good in the hospice or home visit, community visit, we have like a multidisciplinary approach and collaboration teams, so they can cover more patients community in terms of many disciplines, sorry. And also we have to expand and enhance the treatment options for the patient with ESRD. So like now we discussed before like hemodialysis numbers, patient are ongoing hemodialysis are too much compared to PD and also transplants. So that's why, because we know patients on hemodialysis, there were very high risk for patient to have cardiovascular issue. That's why we have to convert patient to peritoneal dialysis, and we have to find more donors that able to donate the kidney to our patients. Okay. As you see, the numbers of patients which are, that's why I say like we have to convert this. Why I saying that we have to convert all the patient HD to PD, because from these numbers, okay, from the means like 17% of patient with HD are having the high BP that can lead to cardiovascular compared to patient PD, okay, which is the percentage is very low. That's why from HD patients, from the government strategies, we want to convert all the HD patient to the PD. And also how the PD patients have high cholesterol serum values. this is also become burden to the patients. So as the conclusions, in view of growing number of CKD in Malaysia, especially those due to diabetics, we need to be more aggressive on CKD preventions, like how we're going to retard the CKD, right? We're going to manage the hypertension, we're going to manage patient diabetic mellitus, and also provisions of renal replacement therapy is not economically sustainable in the long term. And hence, more efforts must be direct to early detection, CKD, instead of to spend more money to patient to treat the patients. Instead of, we have to make sure we prevent these conditions to prompt happen. This, after all, the point of which treatment has big great capacities to make a difference. ESRD has now become the much published issues, and level awareness is high even among the publics. All that is right now is political. We support the causes and to provide the necessary resources for the implementation CKDs and the prevention strategy. So it's mean like it's not only like you focus. Like it's not only one person that handling this prevention CKD, but everyone, including nurses, physicians, pharmacists, dietitians, and also patient itself, have to work together to make sure these strategies are achieved. And also, we're going to reduce the numbers of CKDs by next year if we are possible. So this is the guidelines, so we can refer for the guideline for the nurses. Okay, so for the nurses out there and for the students, maybe you learn on renal this. So this is like a few guidelines. KDIGO 2024 at kids, and also the management CKD is very helpful. If you want to establish the home visit, the hospice care for this CKD, or maybe you are matrons or manager, you want to start the program to retard the CKD, to manage the hypertension, what is the parameter that you have to use, what is the medication that you have to use. So you can refer on this Malaysian, all this you can find from Google. Just type the CPG for CKD, and also you find the KDIGO 24 clinical guidelines. And also this is very important, like what I mentioned, the X-KIT medium strategies on CKD. So when we have this kind of guideline, of course, we're able to manage this CKD is as a one nation. Thank you so much.
Thank you, Mr. Muzahir, for the insightful presentation. So, dear viewers, if you have any
If you
question,
have any question related with this, because of the time restraints, I think like I am able to read all the comments. So maybe you can leave left the comments
okay,
on the comment sections.
comment
Maybe if
session.
I have the time, I can
Yes. So far, there's no question yet. We're waiting. That was very insightful presentation, Mr. Muzahir.
let me check on the our Facebook if there is any question from there. Maybe from the
Yeah.
comment section. I see Madam Fatmawati. Madam Fatmawati is actually my lecturer for my post-basic. Thank you for watching, Puan. Yes, Sasiga agrees. It's not like we cannot look like nurses in renals is like very slightly, because as a nurses in healthcare in our dialysis center, like you don't have like physician all the time. That's why it's very important for nurses to be able to manage some conditions that occur during the dialysis treatment. So to be the nurses in the renal area, especially in managing the dialysis treatments, is crucial for us to really know what we have to do to have a good knowledge and also competency how to manage the patient, especially in managing the complication during the hemodialysis.
Okay, I think we have Arya Nasir. It's just a good comment here. Very well planned and informative session. Can you please shed light on the community health program and role of community health nurses in Malaysia? Mr.
Is
Muzahir?
there a question point? What is
Yes.
that?
Can I repeat again? Can you please shed light on the community health
Where?
program? Community shed light on the community health program and role of community health nurses in Malaysia. This is by Ms. Alia Nasir. Community
Oh,
roles.
Alia Nasir. Wait.
Yes.
Oh, okay. Very well, plain as I mentioned. Can you please shed light? Oh, okay. Community healthcare is actually basically in Malaysia we have like basic clinic kesihatan lah. So in clinic kesihatan, what we important is so important to identify because now in Malaysia what we have done is actually we established this one model is one nurses and one nurses they will taking care for one area of community. So these nurses and doctor what they do is actually they will taking care head to toe of the for the patient health in that certain of community. So that what we have done in Malaysia. So if like before we maybe like this approach is actually only have been done for the midwifery, which is the cover for the numbers for people. But now it's not only for the delivery, it's not only for the labor things, but of course from the primary care head to toe. So from your medications, it's even though how your environments of the house, it was responsibility for nurses in that area to taking care. This is like how government Malaysia approach in the community sector. In and now, if I can share some side like this is not only have been done from the government, some public sector like even in our dialysis center they like what they do is one nurses they have taking care like 10 to 15 patients. It's not only for the dialysis but overall from the medications how the dietitian of the patient they have to review all the blood results. So from the blood result we have to able to manage what nutritional that patient should have, how patients are going to achieve the target goal of the diabetes. So when we go this close approach, so we able to know what is our patient really needs. So we don't go very broad, we go one by one because patients are very special because as an individuals of course you have like a very different kind of personality. Maybe this patient don't want to take a good diet, this patient don't want to take the medication, they want to skip the hemodialysis treatment. So by this approach, this close approach, nurses can really be the good partner for the patient so we can improve the outcome for the dialysis. So maybe from other private sectors, we can use this approach to help like one nurses we taking care for a few patients that was registered under us. Maybe in the clinic, outpatient clinics, also this approach can be done.
Excellent. Thank you. Anyway, that's Alia Nasir. Yeah. Thank you for the question. So I believe time is very jealous of us, huh, Mr. Muzahir? So how is it if we end this program?
Yeah, we are just
Yeah,
giving one
is it?
hours. I also have to speak very fast.
Okay. Let's see. So we have come to the end of the session today, yeah? And we would like to say thank you to Mr. Muzahir for joining us today and providing such insightful information. To our wonderful audience, thank you for joining us at this webinar. We look forward to your comments and participation at future events hosted by the MAHSA University.
Maybe we can have like one Masra, sorry. I have
Yeah.
one questions from
Oh,
Madam Padmavati. She was
oh
asking
yeah.
if patients are having heart problems can convert to the HPD.
Okay, okay.
Of
Thank you.
course, one because like how governments urge, like if possible, if patient have even the patient don't have any issue with their blood pressure or cardiovascular systems, we have to able to to convert patient to PD. Because why PD they provide more advantage. It's not only cardiovascular system, but of course in the patient well-beings, how patient going to life, who want to come to the dialysis center every 2 days. Of course, we want to have like our own life. We want to eat like a normal person. So that's why to convert HD patient to PD is an appropriate treatment. However, there was a few factors that we have to look forward, like accessibility. If patient are able to do the PD itself, but
Exactly.
and of course like the peritoneal itself. Okay, we cannot convert patient to the PD. However, of course, PD they can provide a good cardiovascular management to our patient.
Yes, Mr. Padmawati, thank you so much for the question.
They're
So,
requesting for the attendance with the certificates.
okay. Audience, in case of any further queries, you can contact us through MAHSA website or visit our social media. Have a pleasant day.